everyone, and welcome back to season 2 of Transform 360 podcast. I'm your host, Sabar Shad, a founder, pharmacist, and a mental health advocate. In this podcast, we talk about where science meets compassion and we explore wellness from a whole person perspective. Today's episode is the one that truly speaks to the heart of youth mental health, compassionate care, and the power of community. I'm honored to be joined by someone whose work beautifully bridges clinical excellence and nurturing spaces for growth. Today, I'm honored to welcome Dr. Ayesha Shaheryar to the podcast. Dr. Shaheryar is a child and adolescent psychiatrist currently serving on an inpatient acute crisis unit for youth, where she provides compassionate, evidence based care to children, adolescents, and their families during the time of their most vulnerable moments. She also serves as an associate faculty at Texas A&M Medical School, where she is deeply involved in clinical teaching and mentoring the next generation of physicians. Beyond her clinical work, Dr. Shaheryar is passionate about creating nurturing spaces that are rooted in movement, creativity, and social connection. She is also the co-founder of Noor Collective, a nonprofit that is dedicated to improving the quality of life, health, fitness, and wellness among Muslim women. Dr. Shaheryar, welcome. It is such a privilege to have you here.
Thank you so much for having me on your podcast, Sabah. It's my honor to be here and my pleasure to be talking about my work that I'm really passionate about. So any opportunity to talk about it, and hopefully whoever's listening in today will benefit from our conversation.
Of course. Let's start from the first question. I was just reading a stat last night on Dr. Shaheryar. According to World Health Organization, almost half of the mental health conditions they start by age 14 and often go undetected and untreated. And since you work in an acute crisis unit, first, if you could just define what is an acute crisis unit that people who are listening would understand. And since you work on the front lines of psychiatric crisis, how has that bearing witness to that level of vulnerability shaped you personally, not just professionally?
Sure. So, an acute crisis unit is, we have an inpatient unit which serves a population of adolescents between ages of 12 and 18. These are kids that are, like the word says, in acute crisis, kids that are having significant trauma related symptoms, maybe active suicidal thoughts, maybe they've made a suicide attempt, or have had homicidal thoughts, aggression, property destruction, basically at an imminent danger either to themselves or to others. That's what we define as crisis. And then this population, when they go into an ER, they get diverted to our units where we keep them for about 7 to 10 days, stabilize the crisis, give them all the therapeutic modalities that are available to us, and then step them down to the next level of care. I'll touch a little bit upon what you said, which is that most of your mental health or the origins or the symptomatology would have already begun by age 14, right? That is very accurate because we know that with mental health, there's a multiple etiologies that contribute to a person developing mental health in the course of their life. There's a big genetic burden, right? So a lot of times we're seeing adolescents that have parents with a diagnosed mental illness, or sometimes maybe even an undiagnosed mental illness, but there is a genetic vulnerability. Then there is environmental factors, right? So we see trauma, we see instability in the homes, we see an absence of caregivers or chaotic environments in the household, right? And
Yeah.
on top of that, these kids a lot of times have adverse childhood events. Like it can be overt trauma, whether it's verbal, emotional, physical, sexual, or sometimes even something that we don't think of as trauma, but is traumatic, which is like small incidents that happen over the course of time in the form of lack of safety in the house or lack of emotional connection with the caregiver. And so we tend to think of as that a lot of this pathology arises from a lack of attachment or really problems with attachment, right? Which happen in the very, very early childhood period. In fact, most of our attachment styles develop in the first 3 years of our lives, right? So even as early as that, we start to see infants who've had secure attachment, their needs met, they're being fed when they're hungry, when they're upset, they're being changed when they're wet, versus infants that maybe didn't have that type of nurturing, right? Were left to cry, or weren't fed on a schedule, and so on.
Yeah, that makes sense.
I can see this is really hard to hear, right? So let me tell you a little bit about, because you did ask me, how does witnessing this level of trauma, especially in a very vulnerable population, which is children, impacted me, right? So I'll say this: over time, I have learned to have good, better work life boundaries, and also recognized that in order to care for other people, you have to take care of yourself, right? And that you can't really pour from an empty vessel. And as moms, as caregivers, as physicians, we have to pour into ourselves. And that's what sort of led me to working towards Noor Collective, which is a space to heal women, to nurture them, to fill them with, goodness that then goes out into the community.
That's true. I totally agree, because as parents, people are doing the best what they have seen their parents doing. So they don't understand, what are the signs or symptoms that may develop, because you're saying those important years of our life, like when kids are like just 1 to 3 years old. What are the signs and symptoms that you think, or for a future generations, they should be aware of?
Signs and symptoms in children?
Yes, that parents would know, okay, there's something not right with my kid and they need maybe some additional support.
Sure. So in very young kids, young kids are not going to say, I am depressed or I am anxious, right? It's going to come up, sometimes anxiety will come up as somatic symptoms, like a kid that complains of headaches, stomach aches, I don't want to go to school refusal because I don't feel good, my tummy hurts. Or maybe they'll come up with, they might not be outwardly depressed, but you're sensing irritability in their demeanor. Maybe they are becoming more withdrawn, not wanting to engage with the other kids, wanting to spend a lot of time in their rooms, maybe neglecting, their appetite has suddenly gone down, or they're having difficulties with sleep. Their sleep is disrupted. Are they complaining of nightmares? Are they having night terrors? Or they have a sudden onset of clinginess with the parent. They don't want to let the parent go, right? That can sometimes signal an anxiety or a fear that a kid cannot name. And of course, a lot of times in the very young kids, we see aggression, right? So knowing what aggression is normal versus what is a point where a kid needs help.
Hmm.
Even though when we think about a child psychiatrist's role, we think the role is to diagnose and to prescribe medications, which is accurate. That is a big part of what we do as well. But more than that, understanding what's wrong with this kid, I think we have to understand what happened with this child, or what is happening with this child. What are they experiencing? And to recognize that the kid is not acting in isolation, right? They are very much impacted by the systems that they rotate in, right? Whether that's a home life, that's one system, and or whether that's school, that's the other system, right? How healthy are these systems that these kids are moving in, right? And does that explain the context in which we see their symptoms?
That's true, and those are really important points that you have touched on. I hope listeners who are listening to it can, that can keep those key points in their mind. Those are really helpful. Thanks for sharing that. Another thing, especially during the COVID times, when I was working at a chain pharmacy at that time. I had seen we were also immunizing kids who were probably from 12 to 14 years of age. And I cannot tell you, I had seen young girls and boys with self harm marks so many times. And at that point, I felt hopeless, because I couldn't do anything, because the parent was right there and you can't offer support, because the kid actually doesn't want it, or the parent is right next to them. So those things have always stayed with me. And I understand with self harm, those are coping mechanisms, especially in high schools. Basically, my question is how big bullying plays a part, especially on that level.
Yeah. So when we just talked about systems, right, that the systems that we move in, that the kids move in, impact them very, very significantly. Kids are very sensitive. They're very sensitive to their environments. They're very sensitive to what's happening around them. And so bullying is a big problem in schools. And we frequently see kids that are suffering from depression, suicidal ideation, self harm, that all stems from the bullying in school. It is a serious problem. It is something that needs to be addressed, because kids do not, they don't have a way of separating, of not taking things personally, or of separating what's happening to them. They tend to internalize messages they get from their environment. So if somebody is mistreating them, a lot of times the anger or the sadness becomes directed inwards, like something is wrong with me, and it has a huge impact on the child's self-esteem. Right, you talked about borderline personality, right, which is something we see in patient very, very often. We know that in the population, there's at least 1% of people that have borderline personality. In the inpatient, we tend to see, as much as even 10% of our patients have borderline personality, because this is the personality type that will end up in the hospital most often because of the destructive behaviors. And we know that even with this personality, my way of understanding is that it does stem from some trauma, right? Whether it was an overt, like maybe an abandonment, or it was, lack of attachment or inconsistent attachment, an anxious attachment, a disorganized attachment. But sometimes, because of what the kiddo has experienced, or maybe because of the genetic burden, they go on to develop these personality characteristics, like having mood swings or having just an unstable self of them image of themselves, right? Having a fear of abandonment or fear of like social rejection. And then difficulty with regulating their emotions, even sometimes difficulty with identifying their feelings, right? Being able to name what they're feeling in a given moment.
I agree.
And when those mood swings happen, they tend to be extreme. So when I'm angry, it's 10 on 10. When I'm sad,
Yeah,
it's 10 on 10. The emotions are extreme, and I don't know how to soothe myself. I don't know how to regulate myself without resorting to self harm or aggression or fantasies about suicide and so on.
I agree. That's true. And these are the things that we usually do not talk about openly in our community because they're always considered a stigma um or labeled in a very inappropriate way. That's what I would say. Yeah.
Right. There is a stigma, unfortunately, around mental health. And that stigma, of course, it extends to the patient, it extends to their families. Even, I will say, as far as extends to even folks that are providing mental health treatment. I remember when, back in the day, when I decided to become a psychiatrist, a friend of mine said, "Oh, you're going to go crazy, if that's what you're going to be practicing." And that remained with me, that comment remained with me. And to me, it tells me about the extent of the stigma,
That's true.
and how profound it is, right?
That's true.
So, Sabah, I think you're doing a great job, because the best way to destigmatize a topic is to talk about it.
Yeah. Yeah, I'm trying. Yeah. It took me, I would say, 2 years to get out of my shell that I can at least talk about these kind of things. So that's why I'm trying, and that's why I'm so excited to have this conversation with you. I really appreciate you being here and talking about stuff that, especially not just in our community, Spanish community, in so many other communities, I see it, but we don't talk about it. So, how do you soothe yourself, or how do you get out of your role as a clinician when you get home with your kids? How do you de stress?
Yeah, for sure. So this has been a learning process for me. I remember when I started residency, I would bring home every story, every heartbreak, every sick patient and severe presentation, and I would want to talk about it with my husband. He, I think, sooner than me, realized that there was a big burden of talking about my work, just given the severity of it, and given that, a lot of stories are heartbreaking and so on. So he did a good job of setting those boundaries with me, where he said, "Please don't bring your work home." And even though initially it took me aback, but
Yeah.
I think it allowed me to develop like just healthier ways to process what I was experiencing. So the first thing that I did back when I was in residency was get a therapist myself. And my therapist was also my therapy supervisor. He was somebody who was kind of very advanced in the field of therapy, had been doing therapy with patients for years. And so that became my outlet. So at the end of the week, I would bring my cases to him, and I would have a place where I could process, decompress, talk about things, get feedback without having to bring it to a family member. So that was the beginning. And then now everything that I preach to my patients, like, I have these conversations very regularly with my adolescent patients that, hey, medications are just one route, therapy is just one route. But other than that, we have to do things that are good for our brain, right? And what are those things that are good for our brain? to move our body every day in a way that feels good, right? So incorporate movement into your life. Get outdoors, be in nature, get direct sunlight, do self care, do things that make you feel good about yourself, right? So all those things that I preach, I also try to practice, and that helps me maintain my mental health um,
It's true.
while I work with this population.
That's and thanks for sharing that. Another thing I would like to touch upon is how has you being a psychiatrist changed your parenting style, how you treat them or how you talk to them or how you see them in a different way?
Yes, absolutely. I think the knowledge that you get from being a child psychiatrist and helps you sort of recognize the role, the importance of the role that you have as a parent, right? The relationship that the child has with you is the relationship that then they're going to go on to have with the world, right? And the basis of their attachment with you will show up in all their relationships in the future, right? So firstly, recognizing how important that role is, the role of a parent, right? And then also, I think differentiating, knowing how to discipline properly, knowing how to set boundaries that are good for your kids, or knowing that you have to connect before you correct them, right? That I think that's a big key point that sometimes in parents do not get. There's a lot of times they give a lot of negative feedback to the kid or give attention to the kid only when they're making a mistake or when they feel parent feels that they need to be taught like a teaching lesson. But outside of that, that positive attention is missing. So when I meet with dysregulated kids or kids that are acting out, they're not listening, parents are complaining that they're not following rules, they're talking back, so on. The first question that I ask is, what do you guys do together for fun? How are you connecting with your child on a week to week basis? Are you spending any quality time? Is there any activity that you like doing with your child that gives them just positive attention? Like you're enjoying each other, you're getting to know each other, it's a safe space. And a lot of times the answer is no, because we get so busy with our lives that if we're not intentional, we don't create that time. I will say this to any parent of a struggling child, a child who's not maybe not communicating with the kid, with their parents, who's isolating, who's self-harming, or who's acting out. Create that time once a week, even if it's once a week, 30 minutes. We're gonna do a mom and daughter date. I'm just giving an example, right? We're gonna do 30 minutes of quality time doing an activity that we both love. And during this time, we're not going to talk about stressful stuff. We're not going to talk about school and grades and chores and things that are going wrong. We're just going to learn to enjoy each other's company. So, firstly, focusing on connection. And then once we have built that connection over weeks, right, then we start correcting. And sometimes with correction, even you can start with firstly like indirect commands instead of being very authoritative and say, do this. And we can start with giving them options. Hey, would you like to wear your blue shirt or your red shirt? Or would you like to take a bath now or in 10 minutes? That way you feel you've given the kiddo an option. They're more likely to agree because they feel they're in control of making this decision.
That's true. That's true. And I think that's where kids would start trusting and making their own choices as well.
Yes, yes. It also, helps them with decision making and autonomy and stimulates their thinking skills.
That is so important. Thanks for sharing that because that's big because we don't usually talk about these things. So thanks for sharing everything in details. I hope it
Yeah,
helped.
I can, because my work is with families and it's with parents, parenting
Yeah.
is something I can talk about in a lot of detail.
Yes. So it means next time I have to invite you on a topic that's just for parents because as adults we usually do not understand maybe so many other traumas that we may be carrying from our parents, from our other things that happen in life, but we never address them, and then we are unintentionally transferring it to our kids and then to the other generation. So that's another important thing. Thanks for sharing. Another thing, I know we talked about childhood problems in this age of social media and identity problems and academic pressure. Most of the parents, they feel unsure whether they're seeing their teenagers as as a normal teenage behavior or something more serious. What reflective questions do you think they should be asking themselves when it comes to their older kids?
To the older kids.
Yes,
So I
yes.
will say this, that with the older kids, the parents have to work on setting boundaries around social media. because phones and social media is very addictive. We know that it is designed to be addictive. Everyone's feed looks different. It is designed according to what your brain in particular finds most pleasurable, right? So I might be looking at like decorating tips, and you might be looking at cooking recipes, but we know that whatever we look at, it's the algorithm has picked up on what we specifically want to engage with, what content. So it's highly addictive. Every time we see something that we like, we have a dopamine hit, right? So we're getting a lot of like dopamine hits every time we're scrolling. And
Mm-hmm.
sometimes even before we pick up our phone, we start feeling good because we know we're going to be seeing something that's going to make us happy or make us, in at least in the moment, feel stimulated. So we know that this is highly addictive. That amount of dopamine does not mimic real life. So for a kiddo doing their homework, talking with the person one on one, FaceTime, being asked to take out the trash is not going to be as rewarding. And so over time, they're going to lose motivation for their tasks of daily living. And so there has to be boundaries around their social media use that parents have to put in place, right? A lot of parents may also not be aware of what the kid is actually consuming on the social media, right? So we know that since the advent of Facebook and Instagram, so on and so forth, we've also seen that mental illness in kids has increased. 2005 to 2008, that was the time that the social media boom, and since then we've seen increase in mental illness and hospitalizations nationwide in adolescents, right? And so it's kind of followed the same curve. And the most vulnerable, even out of the adolescents, are adolescent females, because they are consumed by these ideals of beauty, and that contributes to low self-image, body dysmorphia, eating disorders. And so that's another danger, right? That a kiddo, that not just a kiddo, any human being, we have evolved to believe what we see with our eyes. So even though we might cognitively know that there's makeup, there's filters, there's face tuning apps, are we will still believe what we see.
That's true. That's our problem, that we are very attuned to see actually visualizing things, and that just stays in our mind rather than it does not matter what we know is right or not.
Yeah. So I will say to the parents of adolescent kids, if they're staying up at night, if they're, wanting to becoming disengaged with their other activities, losing interest in their hobbies, maybe they're not taking care of themselves, they're not brushing, showering, they're becoming a little isolated, the grades are failing, or,
Mhm.
just struggling in school, there's some school refusal, there's irritability.
Mm-hmm.
And all those things are worth having a conversation about.
That's true. That's true. Thanks. Yeah. Thanks for saying that. And I do see not just behavioral problems. I understand teenagers, they have, as they're growing up, they have a change in their hormone patterns and those kind of things. But it is important to realize what is a good behavior than a disruptive behavior.
Yeah. In the field of child psychiatry, all behavior is communication. And so
Mhm.
realizing that they are communicating something with their behavior,
That's
whether
true.
it is the impact of what they're consuming, what they're experiencing, or what they're feeling. Even when they can't really put a finger on it, they're communicating with their behaviors.
That's true. So they, in a nutshell, they are trying to tell you something. And another thing, this was not part of my questions, but boundaries. You have mentioned about boundaries. So is there an easy way? Because for us as Southeast Asian community or even other communities, we do not understand boundaries, what boundaries are. It's not like a physical parameter. What are boundaries?
That is a great question. So I think how I would describe boundaries are that boundaries are what protects us from other people. It's the kind of like that invisible line around us that separates where we begin, or where we stop and somebody else begins. And so the boundaries can be obviously physical. They can be related to physical space. Sometimes with little kids, you might have to set boundaries like, you can't pull my hair, or you can't climb into my lap. Like, you can't treat me like a jungle gym. Like, I used to always tell my kids, like, I'm not your personal, like, climbing space. So sometimes physical boundaries. And then, of course, they can be emotional boundaries, right? Like, what topics that are safe to talk about, what topics cannot be talked about, such as I give an example of like the boundary that my husband set with me, where he said, do not bring your work home.
I agree.
I think boundaries protect our energy, right? And so sometimes we have to set those boundaries around, like when we say around our work, right? Which is my work finishes at 4. And
Mhm.
so maybe setting that boundary with work, like I would
Yeah.
like to not be contacted after hours, right? Or right, if you're not on and you're not on call, then it has to wait until the next day.
Wait until the next. That's
And
true.
then of course with kids and with family and family members, there's boundaries around how you want to be treated, the tone of somebody's voice when they're talking to you, right? Or how to handle conflict. Like I tell my kids when they're angry, we don't talk. I just tell them, kiddo, you're upset, you need to go to your room to calm down, and we'll talk about this later.
That's true. I totally
Yeah.
agree. Yeah.
So those are boundaries, right? And our boundaries also help us like communicate a little bit more effectively, right? And reduce conflict, increase our co-regulation as a parent.
True. That's totally right. Before we move to another question, another would be, if there's any parent or a child who is listening to our discussion today, and they might feel misunderstood or unseen or alone, what would you want them to hear from a compassionate heart? Not as a clinician, but as a human being who sees their pain, but also sees their potential as well.
Yeah, so for anyone listening, I would say that to not be embarrassed of what they're experiencing. Your feelings are valid. Whatever you're feeling, there is in our society, there is also an idea that some emotions are acceptable and some emotions are not acceptable. So it's okay to be happy and curious and excited, but maybe it's not okay to be sad, or it's not okay to be jealous. It's not okay. It's definitely not okay to hate someone, right? But a lot of emotions, we have put them in these boxes where they're unacceptable to us, right? And anyone who's listening today, I will say your emotions are valid and your emotions are acceptable. Sometimes acting on certain emotions is not acceptable, right? So and behaving in a way, for example, if you're feeling sad and you self-harm, you cut yourself, and that's how you cope, that's a maladaptive way to cope. That behavior is not okay. But feeling sadness because something happened in your life that was very hard, maybe there was a loss, there's grief, right? Maybe for a mother right now, mothering is hard, difficult, all consuming, you don't have enough support, and you're sad. Your sadness is allowed. So just making space for our emotions. I think sometimes the first step is accepting what we're feeling, accepting what we're going through.
Thank you for saying that. That's just beautiful. And the other thing I would like to, I know we don't have a lot of time, but I would like you to touch upon a little bit about autism. Autism is another thing. It has been there for like a while, but now it is being brought up in different discussions in different news media outlets and those things. So, what would you say about autism and how much genetically, like
Yeah. So, the etiology of autism, it is difficult to understand because it's not clearly established. We don't know what causes autism. There's a lot of myths out there. Of course, some folks think, something to do with like vaccines. That's a pretty big misconception that exists in the community, right?
Tylenol?
Right. Or Tylenol or something the mom ate or, the truth is it is not clearly established. Some genetic disorders do play a part, like if there is a chromosomal abnormality, or if there is something at the level of genetic mutation, deletion, duplication at the chromosomal level, and we're seeing certain neurodevelopmental disorders that can be a predisposing factor for autism, such as Fragile X, and there's other disorders as well that paint a very autism spectrum type of picture. Now, autism is on a spectrum, right? Now it's called an autism spectrum disorder, which means people can on the spectrum can look very different. They can be your level 1 autism, which is your high functioning autism, previously called Asperger's disorder, and now part of the spectrum. But
Mhm.
these folks may not look any much different from you and me. They may have good verbal skills, they may have good IQ, they're very intelligent, but there's differences in the way they communicate. Their verbal and non-verbal communication, there are deficits, right? Maybe there is some stereotypical behaviors, there's some repetitive behaviors. A lot of times there's sensory sensitivities and overload, right? So we see that these folks have a hard time in crowded crowded rooms, bright environments, overstimulating environments, right? In motherhood or in early childhood, we'll see a kid that is resistant to change, right?
Mm-hmm.
Something changed in his structure, in his schedule. Bedtime was delayed. There was some type of sensory sensitivity, maybe to fabric. Mom tried to put on a shirt with buttons or collars, and it was very aggravating.
Yes.
We'll see these sensory sensitivities, and then we will see a dysregulation from the child that is out of proportion to the stressor, right? Like prolonged tantrums. We see prolonged tantrums that the kiddo cannot be soothed. This kid is irritable, fussy, crying, angry, and maybe there's aggression, but it's tied to that sense, that overload, or to the sensory sensitivity. And sometimes we see that in terms of food, being an extremely picky eater, having difficulties with certain textures, tastes,
Mm-hmm.
even just the look of food sometimes, right?
Wow.
So having that picky eating. And so we have the high functioning autism, but then we also have the level 2, level 3, which require more support, all the way to level 3, where the kiddo may be completely non-verbal. They may have some stereotypical behaviors, or like stimming, like they're moving their fingers, or they're, maybe sometimes like self-mutilating or head banging, right? Severe symptoms. So it exists on a spec, and I think for the red flags are, some that the parents need to watch out for. Any kid, for example, the first step is social smile, right? When you have a young kid, and I think every parent remembers that moment when the kid made eye contact with them and gave them their first smile, right? And it was not a reflexive smile, because it's a very intentional, like, I recognize you, and I'm smiling back at you, right?
Yes.
So for an autistic child, that may be absent, right? You may not have that social smile. And then the second is, we call it social emotional reciprocity, right? Where the kid is going to engage with you as though you're human, and they recognize that you're human, right? So they're saying to the parent, "Pick me up." Sometimes in the autistic child, we will not see that response of "pick me up,"
Okay.
right? Because they may be engaging with you as well as an object, and not as
Mm-hmm.
another human being, right? And so there'll be differences in how they play, and that's our job, to observe it, right? Are they learning to, like, are they making the cars slide with their wheels, or are they holding their cars and just banging them on the table, right?
That's interesting. Okay. Yeah.
How they play, are they playing, are they not playing, and then how are they playing?
That's a
For autistic kids, spontaneous play with other kids, there's a deficit, right? They may not be able to make friends, or they may not be able to, they may be parallel play, but they aged when they get to that cooperative play with other kids, they may be deficits.
those are some really important points, and we usually see these kind of little things, but we're not aware that
Right.
that
Yeah.
this is
And
actually
of course, I
happening.
want to touch upon speech delay, which is the main thing that the parent will see. So, any kid with a speech delay, or even like a motor delay,
Mm-hmm.
they're not walking or talking at the right time.
Yeah.
I would say, have a talk with your pediatrician, because that's your first point of contact. And usually, pediatricians are screening for autism. They're asking parents, like, and I think you'll remember this from your pediatrician, like, are they saying their consonants? Are they saying their vowels? Two-letter words? Are they able to say a full sentence? So on.
So that's true. Thanks. Thanks for sharing that. Those are very important points. Thank you so much for sharing everything, Dr. Sharia. Let's zoom out from your clinical practice. So I know you're very passionate about creating nurturing spaces that are rooted in movement and health and fitness and social connection. And since you have co-founded a Noor Collective, that's a nonprofit and that's dedicated to improving the quality of life, especially among anyone, not just specifically to Muslim women, but anyone. So, what inspired you to move beyond, your um, your walls of the hospital and actually building a community-based wellness space?
Yeah, well, Noor, we talked about this a little bit before, right? Being a practicing physician and a mother, it was very important for me to have ways to support my mental and physical health, right? So I've always been passionate about fitness. And this was even before I had kids, more so, more intentionally after I had
Mm-hmm.
kids. But in the past, I was a runner. I ran a marathon, I ran 2 half marathons. I was really into fitness. So, the No Collective started as a conversation between two friends. My partner Dana and I, we both passionate about fitness, and it started as just a conversation. And our initial plan was to gather a group of 10 girls that can just work out together, right? But we posted our first class, which was supposed to be
Yeah.
a yoga class.
Okay.
And I remember we got 40 signups.
Wow.
And we realized, okay, people want to join us, they want to do this, there's a need.
That's
And
true.
so it took on from there. We really, I won't want to say that this was something that was completely imagined and curated by us. I would say we had an idea and we responded to the need because the need existed in the community. There are not a lot of places that are centered around wellness for women and who really are designed thoughtfully and specifically for
Yeah.
women's health. And so we started off as a fitness brand. We were offering our run club and Pilates and yoga and cycling and rock climbing, like all types of ways to move our bodies. And then we grew into more into wellness as we saw that there was a need for social connection for women to step out of their homes, especially mothers who were with kids all day or all week at the end of the day, who could step away and then connect with other women. It was really healing for them. They can be really varied. It can be as something as simple as a paint night or pottery, or it can be something a little bit more advanced like a cooking class or how to make sourdough bread or candle making and so on.
And that's amazing. Thank you for doing that. And
It's been so rewarding. We, in the winter, we did a mental health series
yeah.
which was a Zoom
Mhm.
series
Okay.
with, I believe we talked about it briefly.
Yes. Yes. Yes.
Yeah, where we touched upon different topics. Whether we started with depression, anxiety, we had talked about seasonal affective disorder, we talked about grief and loss. And a lot of times where I saw that the conversation was, with the depression, anxiety going a lot toward postpartum depression, postpartum anxiety, how to cope with being a new mom. And then with grief and loss as well, I think given, the period of life that a lot of these women are in, in our midlife, and you have the caregiver burden for taking care of like young kids but also older parents, there was a remarkable number of people dealing with grief that they did not know how to give words to,
That's
right?
true.
And so it was very therapeutic to be together and be able to talk about it.
Yeah. And thanks for creating that safe space, because a lot of people would know stuff, but they would not share it unless they know they can trust the other person. So thanks for doing that. Yeah. As we now, all of our questions are done, but I would still like to have a quick rapid fire round.
Sure.
If children ruled the world, bedtime would be. Yeah. And stop messing with the
Leave us alone. Coffee.
coffee. Okay. One fun thing that people would be surprised to learn about you.
I sing for fun.
Okay. Okay. The hardest part of being a clinician is resisting snacks, naps, or both.
Naps.
Okay. Okay. If you could have one superpower, what would it be?
Read other people's brains. I don't know if
Okay.
I want to.
That's true, but it would be interesting.
I think time travel.
Okay.
That's what I want. Yeah.
Okay. One thing that you would tell your younger self now.
Do not stress, right? Things will happen in their own time. And I read this quote, which is, to worry is to suffer twice, right? First, in the anticipation of that bad thing happening or that outcome that we're wanting, not getting that outcome. I'm choosing not to suffer.
It's true. Okay, the last one. It's okay if you don't know it. If mental health had a theme song, it would be, and it's a hard one. Now even I'm thinking.
Gosh, that's so hard. Mental health has
We,
a theme
we can
song.
just pass it if you don't.
Yesterday by Beatles.
That's a good
Yesterday,
one.
all my troubles seem so far away.
That's awesome. Thank you. Thank you so much for playing along. I really appreciate you being here today. As we close our conversation today, I want our listeners to leave with this one reminder that healing does not require you to be strong at all time. It requires you to be honest, patient with yourself, and willing to seek care when that truly works for you. And if you found meaning in today's conversation, please subscribe, share this episode with someone who might need it, and leave us a review. Until next time, take care, stay balanced, and keep choosing your well being one small step at a time. And thank you so much for joining us today, Dr. Shaheryar. We'll definitely have you back again. Thank you so much. It was an amazing conversation.
Thank you so much for having me on your podcast, Sabah.
Of course.